like to thank the AEP, and thank you for that kind introduction, Dr. Karash. I'd like to especially thank the Educational Committee, because I am a newbie at education here. I've only been doing this for 4 years, so it's quite an honor to speak before this group here. I'd like to get through the no disclosure statement. I have no conflicts of interest at this time. And as Dr. Karash says, I am at the University of Utah School of Dentistry, and I joined the school. We are a brand new school. I joined them 4 years ago. We've graduated 3 classes so far. Our enrollment is about 50 students per class. We have no graduate students, as mentioned. We have 2 full-time periodontists, but we're down to only me because we have an open position at the school at this time. So it's up to myself, our 2 full-time dental hygienists, and our 2 one-day-a-week adjuncts, who are very, very helpful. So we are covering everything from the classroom to the clinic, and we're trying to do that as well as we possibly can here. Now, the new classification system that was rolled out last year has been the basis by which we have changed our curriculum quite a bit, and it's been very, very helpful and I think very useful to the students. As we rolled this out, we started out with gingival health, gingivitis, periodontitis particularly in the middle, and the peri-implant conditions and peri-implant diseases. That's where we started. And then we moved to the green outlines of the other periodontal conditions. So we've covered all 15 boxes within our school following the rollout last June. We initiated the care among all 4 classes, but in various stages depending on where they were. I'd like to spend just a few minutes on some of the other conditions, and then we'll talk about the staging and grading quite a bit. So some of our experiences we've seen is we've had a little bit of challenge with the new terminology. The violation of supracrestal tissue attachment doesn't roll off the tongue quite as well as violation of biologic width, but that concept is certainly alive and well in our school. And in fact, with our school, we actually charge only $100 for crown lengthening surgery, just to be sure that the students are able to do the proper treatment and get good patient outcomes. So the concept of violation of supracrestal tissue attachment is certainly very much a focus of our education, particularly on the clinic floor. Now, mucogingival conditions, the gingival phenotype versus gingival biotype, we've moved into the gingival phenotype fairly easily. And the best way for us to share that information was the visual test. So we instruct the students, place the probe in the marginal gingiva. If you see the gray hue of the probe outlined, as on the left, then that's a thin phenotype. If you don't see the gray hue, then that's a thick phenotype. In this particular case, it's from the same patient. So they understand that it can vary in different sites for the patient. So this has been very helpful to get the point of a thin phenotype across. The RT1, RT2, 3 gingival recession designations have been very helpful as the students have looked at the different recession types, particularly with regards to how much root coverage can be expected following a connective tissue graft. So RT1, 2, and 3 have been very, very helpful for our students on the clinic floor. Now, peri-implant mucositis, peri-implantitis, the criteria that are established now have been very, very helpful for the students to identify when you have a mucositis versus an implantitis, and they have very differing modes of treatment and expectations for those. So I'm not going to spend very much time on this other than to say the classifications have been very helpful for these 2 diseases. The last thing I want to talk about other, and I'd like to focus in on number 2, because this has been a paradigm shift for so many of our general dentist attending faculty and some of the periodontists that I've talked to out in the practicing world. Number 2, there is no credible evidence to support the existence of abfraction or implicate it as a cause of gingival recession. That's a huge paradigm shift that has been very challenging to overcome within our institution. So let's move on to staging and grading. We have introduced this to all classes during the academic year last year at various times. We felt it was really important that the D4 class get this information before they graduated, and we got it to them in April before they graduated, because a couple of months afterwards, they might be encountering this terminology, and we felt they really needed to understand this. So all 4 classes have received this both in the classroom and on the clinic floor. But we also continue to teach the 1999 classification because our notes, even though we're a new school, our notes are going to reflect the 1999 classification in most instances. And we also felt that as the students graduated, went into their various practice settings, they would have to understand what that terminology might have meant from the past. So that's why both 99 and 18 are being taught at our school. Now, the biggest thing is we emphasize risk, as outlined by yellow on the screen. So that's been the biggest game changer for us, is the students recognize that not all periodontal disease is the same, that the risk is what we really need to consider as you evaluate your patient. You're all familiar with the staging and grading tables from the AAP. These have been best sellers with the AAP. They are taken very regularly when we bring them on the road to other areas and meetings. But we've taken this table, we've modified it somewhat. While on the board, Dr. Kornman gave us a lot of information in May, about a month before it was rolled out, to explain a lot about the staging and grading. And then I attended a meeting at the Midwest Society of Perio in February 2019 that gave a little more clarification. Dr. Kornman wanted me to share with you that you will see a lot of these concepts in which we've modified on the tables that coming up in an upcoming J. Perio article. So this is coming up, and I think this will be very helpful for you to understand some of the nuances with staging and grading. So we've taken this table at the University of Utah, and we've modified it somewhat with a few explanations. As you all know, stage 1 through 4 is very closely correlated to cancer diagnosis in terms of stage 1 versus stage 4. And Dr. Kornman mentioned that with stage 1, fairly early disease involvement, relatively easy to treat through scaling root planing. But stage 3 and 4, you cannot expect scaling root planing to be the sole treatment for stage 3 and 4. And right to the red line is the stage 3 and 4. And that's been very important for us at our school because the students are supposed to reach out to the perio department anytime they had a stage 3 or 4. So as Dr. Kornman mentioned, 70% of your patients that you'll see are likely to be in stage 1 and 2, and 30% will be stage 3 and 4. What's been particularly helpful, if you see on the stage 3, 4 at the bottom, our students had a lot of trouble, said, what's the difference between 3 and 4? They're both severe periodontitis. Well, with stage 3, you're in danger of losing the tooth, and stage 4, you're in danger of losing the entire dentition. So when he correlated it to terminal cancer, stage 4, the terminal dentition for stage 4 is something that seemed to have resonated to the students. So that potential for tooth loss has been very helpful versus potential for dentition loss. Now grading, Dr. Kornman said, default to grade B until proven otherwise, and that's what we've seen. Most of our patients, at least within our clinical setting, are definitely grade Bs, a few grade Cs, and with our patient population, very few grade As. So most everybody's going to be a grade B. Now, looking at it individually, the interdental clinical attachment loss, 1, 2, 3, 4, greater than 5, that's been pretty easy because it's a carryover from the 1999 classification. The radiographic bone loss is new and different. That one, I think, has been very helpful with the radiographs. It also has maybe some concerns. The division of the destruction based on the coronal 1/3 and extending into the middle 1/3 has been helpful. First 15 or less than 15% root bone loss is stage 1, up to 1/3, stage 2. Once you get into the middle 1/3 or beyond, it's stage 3 and the vertical defects. My concern is the very bottom, and this is what we're seeing with some of our attendings. I think there's going to be a little potential to regress to the diagnosing of periodontitis on the radiograph. As helpful as it has been to look at the bone level on the radiograph, I believe that we're missing out with some of the stage 1 cases that may not show radiographs. So the easiest way that we found, and this is a tip from Dr. Kornman, is he called this the ladder technique. So we've developed a ladder dividing the coronal 1/3, middle 1/3, apical 1/3. And it's very different on a very short root of those central incisors versus the normal root of the lateral incisor. So for example, if you had 3 millimeters of attachment loss on that central incisor, that may be into the middle 1/3. and that tooth's in danger and at risk for the future, and that's now a stage 3 periodontitis classification. So this has been very helpful for our students as a visual for them to understand the importance of looking at the different 1/3 of the root. Now, complexity, this is on the table. The horizontal bone loss will be very common for the stage 1 and 2, and then the vertical stage 2 and 3. What we've especially used, the stage 4, is the number of teeth that remain and the opposing pairs of teeth. So you may have a case with perhaps only 3 to 4 millimeters of attachment loss, but if there are numerous missing teeth due to periodontitis or upcoming loss of teeth due to periodontitis, we've downgraded those cases to stage 4. I'll be interested to hear what you are doing at your institutions because that may not be consistent, but that's been our interpretation, that once you get to that point of so few teeth, the rest of the periodontium is certainly at risk for periodontitis. And the panoramic has been very helpful to just count the number of opposing pairs of teeth to get to a stage 4. With regards to the extent and distribution, that's a carryover from 1999, so that's been easy to reinforce with the students with our new staging of 2018. As we go to grading, because we're a new school, only in operation for 3 years, we don't have 5 years of records to see if there's 2 millimeters loss over those last 5 years to put them into grade C. But what's been really easy for the students is they look at the worst tooth of bone loss, they get that % bone loss divided by age, and then they get to the ratio. So that ratio has been very easy to determine so they can place the patient in the proper grade, at least in terms of the progression of the disease there. Now, in terms of the grade modifiers, the systemics, this has been fairly easy for the students to recognize the glycemic control and the smoking risk that the patient might have. So that's been straightforward, but it's been really helpful for the students to be sure and check into the diabetic status of their patient. So that's how we've introduced it on the floor. Now, what's been our experiences with our students? Maybe not exactly what we hoped for coming out of the classroom, but I'll just share some of the comments that patients have. I don't know why they changed. It's still treated with scaling and root planing. Obviously, we didn't get to that student correctly. Now, the last two are a little better. They say, well, I understand perio surgery is probably going to be recommended after I do my phase-on treatment and do my reevaluation. And also, it's right of the red line. That's something that's a patient needs more treatment. And definitely, when we really know we hit the student properly was, I need to refer to a periodontist right of the red line, and I'll make that determination after my reevaluation to consider a periodontist for help. Now, they've had challenges with clinical attachment level versus clinical attachment loss. Sometimes they focused in only on one criteria, 4, 5, 6 millimeter probing depths or mobilities. They just look at one thing, and that's the issue, the shades of gray with this here, and that they need to look at everything to come up with the appropriate classification. And they're still adding chronic, especially to our D3, D4s who learn 99. They may say, I have a stage 2 grade B chronic periodontitis, so we remind them to take that chronic out of there. They're still wanting to do a generalized stage with a localized stage like 1999, so we're trying to break them of that habit a little bit. And then in terms of the grading, sometimes they're looking at just the rate of progression and not the systemic, or the systemic and not rate of progression. So we're emphasizing you need to look at both to come up with the grade. I think we've also had some challenges with them understanding that maybe a stage 3 grade C at age 30 is a little different than stage 3 grade C at age 60. So the aggressive periodontitis concepts are still in their mind. And consideration of smokers. What do we do with smokers? And now especially vaping, because Utah has a particular problem with vaping. But however, overall, the good news, they've adapted well and quickly. They certainly understand the patient's unique needs a whole lot better, and they've incorporated the concept of risk as they're evaluating their patient and treatment planning. Now let's talk a little bit about faculty challenges here. Probably the number one challenge is not picking up the perio probe, which happens not infrequently here. Or they may say, I don't see the bone loss on the x-ray. You don't have a periodontitis case. Therefore, you do scaling or adult prophy, not scaling root planing. It's been very interesting to see the different ages of the careers of our adjunct general dentists. The early career, they've adapted very well because they were familiar with 1999. Mid-career has been a little challenging. And I use mid-career because I was on the task force to evaluate the annual meeting, and those were the folks that were most disgruntled with our meeting. And that seems to be a very challenging group to work with at our school at that mid-career range. Late career, some of those folks are great. They're CE junkies. They can't learn enough of the newest and greatest. But we also have a few adjuncts that might be about 4 generations behind. I have one attending who actually talks about periodontosis. And the private practice world comes in. We get paid by treatment, not diagnosis. We just want to get to work. It takes too long to do that exam. And worst of all, even though some of our adjuncts know the stage 3 and 4 grade Cs are supposed to reach out to perio, some of them have actually said, you don't need perio. I'm a licensed dentist. I can help you. So that's just been an observation. And with the school, we're a generalist based model of dental education. We don't have the opportunity to oversee their dental or their perio exam, diagnosis, and treatment plan. It's not till they begin therapy that we make the corrections for accurate assessments and diagnosis treatment planning. And without a graduate program, the students don't see the benefits of perio surgery, limited opportunities to do perio surgery. And our patient population simply doesn't have the means to do perio surgery so that they could see benefits of phase 2 perio surgery. And our Medicaid population doesn't have that. So that's been our experiences at the University of Utah. I think I'll hold off questions until the Q&A session. So I'd like to thank you. I really appreciate this from my days at Nebraska through my career in Wyoming and now at the University of Utah. Thanks so much.